So thank you also to those of you online who are following us today. I just glanced at the chat, and there are many congratulatory, many thank yous, just following on our keynote and our commentary. So thank you again. And to all of you online, please keep your questions, feedback coming in. We value your thoughts. And on to panel 3 now. So this is AI for the future of health. And I'm very pleased that we have with us Mr. Konstantinos Georgaras. He is the newly minted CEO of the Canadian Intellectual Property Office. And I believe this is among your first official speaking engagements.
Very first, Pina.
Very first. I love it. Yay. Okay, so York is a place of firsts, right? And here at Osgoode, so thank you so much for that. I'm delighted to hear that. Of course, in his role, Mr. Georgaras provides strategic direction and leadership to the Canadian Intellectual Property Office, and CIPO's come up quite a bit already. And he really ensures the provision of world-class IP services by granting IP rights and providing IP awareness and information, really to the public, right, to Canada. He also represents CIPO and Canada's interests both nationally and internationally. Mr. Georgaras leads legislative, regulatory, administrative, and operational policy related to IP framework that CIPO administers. He provides expert advice and broader IP policy analysis, policy development, and framework modernization. He leads the Canadian delegations on key bilateral and multilateral initiatives, such as strategic WIPO committees, the Asia-Pacific Economic Cooperation's IP Committee, and other fora, all to develop and advance Canadian IP positions and interests internationally. Mr. Georgaras began his career in the public service in 1984, so he's definitely a long-time expert in all things government, and has held strategic and executive positions within the departments of ISED now, and within Science and Technology and the Innovation Council. The list goes on. Mr. Georgaras has extensive experience spanning strategic, economic, and legislative policy with direct responsibilities for IP, innovation, insolvency, and industrial and labor market policies. He holds a Master of Arts in Public Administration from Carleton University and an Executive Certificate in Public Leadership from the John F. Kennedy School of Government at Harvard University. And I'm proud to say he's been a long-standing member of the IP Osgoode Advisory Board, a dear friend of the university and the law school, and also an avid supporter of our IP Intensive, where we get to send our students every year to Ottawa, and also the IP Innovation Clinic. So a very warm welcome to you, Konstantinos.
Thank you very much, Pina, for the kind words. I just want to confirm, oh yes, we do have our fifth participant on the panel. No, it's quite all right. So welcome to this panel on AI for the future of health, data IP, and equitable access to personalized healthcare. As Pina mentioned, I'm from the Canadian Intellectual Property Office, and we of course are looking at AI from a policy perspective, but also in the adoption. And here today we'll talk about adoption of AI in healthcare. I really wish we would have had a bit of time just to breathe in what we just heard from Dean Zimmer and Justice Rothstein. Very important, meaningful presentation. I really will be reflecting on those voices that we heard. Thank you. I had the opportunity to meet the panelists virtually a few days ago, and believe me, you're in for a treat. We have a number of different perspectives around AI in healthcare, from a health practitioner perspective, from a data perspective, and legal perspectives. And it got me thinking a lot over the last week or so about what does it mean? What does healthcare mean in the age of AI? And I was thinking, you know, if Hippocrates had to rewrite the oath in an age of AI, what would it sound like? Would it be different at all? I didn't know who to ask, so I actually went to openai.com, and a free service. I used the DaVinci 002 model script, and I put in the following 9 words. Create new Hippocratic oath for doctors using artificial intelligence. In 3 seconds, this is what AI told us about a new Hippocratic oath. 4 sentences. I pledge to use artificial intelligence in a way that benefits humanity and does no harm. I will use AI to save lives, to improve patients' lives, and to protect the vulnerable. I will never use AI to create weapons or to harm people in any way. I'm really interested in the transparency there to see how AI generated that one. And finally, I will always strive to stay at the forefront of AI technology and to use it responsibly, ethically, and with care. What does this mean? I mean, this is more than just a party trick here. AI is being used in many, many ways. It's in front of us. The future is now, and it's being applied everywhere. It is pervasive, and it is being used in healthcare. So with that, let me now turn to our panelists. So of course, we're all eager to see AI broadly and successfully integrated into healthcare. And whether or not we're eager to see it deployed, it's already happening. It is inevitable in many ways, and it is being deployed extensively. Recently, with the pandemic, this has highlighted the importance of data collection and data analytics for both personalized healthcare and public health. The pandemic has also reminded us that inequities exist within our healthcare systems, and simply taking available retrospective data to make predictions may do nothing more than just move old problems forward or potentially create new ones. So, with that in mind, I will not take any more time, but I'll turn to our esteemed panelists. And I'll ask you yourselves to quickly introduce yourself and think about 2 questions, if you could answer them. What do you think has been the biggest success in healthcare AI over the past few years? And what do you think is the biggest barrier that we still need to overcome if we're going to see real successful progress in this space? So what are the benefits, what are the barriers, or potential issues of concern? So let's turn in to our esteemed panelists, first with Dr. Devin Singh. Doctor.
Well, in true physician fashion, I was a bit late, so I apologize about that. And so I'm an emergency doctor at SickKids Hospital. I also have a master's in computer science, and so I write machine learning code, and I really focus my research on the translation of AI into clinical practice to really drive automation and improvements in the way we deliver care to our patients. I also am the CEO and co-founder of a health tech company that's sort of born out of SickKids called Hero AI. And that company came from this issue where we were building these super cool models in the academic space, but there was no way to get it into people's hands. And that journey of trying to figure out how to get AI into people's hands has given a lot of insight around some of the wonderful opportunities and barriers. Did you want me to talk about those now, or we'll finish our introductions?
Please.
Yeah, sure. So, I mean, some of the incredible opportunities at hand are around, I think, clinical automation. There are so many inefficiencies. If you've gone to an emergency department lately where you check in, your data is put into an EHR, and we all know when we look at that data exactly what tests you're going to need. You're going to need an abdominal ultrasound because we think you have appendicitis. Maybe you're having some urinary symptoms and your kiddo needs a urine test. But you'll wait 6 hours, 8 hours for us to see you, then order that test, and then wait another 4 hours for the test to be done. There's just so much inefficiency in the time spent waiting. And so I think there's a wonderful opportunity to leverage predictive analytics to get common orders placed in a real-time fashion, to get things done in parallel while you're waiting, just drive efficiency. And so I think that's probably one of the biggest low-hanging fruit opportunities for machine learning right now, is in the space of clinical automation. And the opportunity is really coming to life because of the birth of these these EHRs spreading across, all of our, different health systems and across the country. Really, there's a lot of digitization of healthcare, which creates the data and that fuel needed for a machine learning model to come to life. Some of the greatest barriers, and these are really important barriers, I'd say, probably halfway down my list would be around the regulatory landscape. And so there's a bit of confusion on how do we take these models, build them, and then translate them in a way that ideally sort of fits with the current regulatory space, but we know that the current space isn't ideal. So then what do? We're trying to exceed with the regulatory and with the privacy laws and the laws of the land. From a SickKids perspective and a startup perspective, we're trying to exceed those benchmarks because we know that the bars should be raised. And so that creates a bit of confusion and a bit of grayness in the space. The models that we build are adaptive. Health Canada right now doesn't regulate adaptive machine learning models. So that just means a machine learning model that's continuously learning. Those are the models of today and of the future, but they can't be regulated right now. So that's a major barrier, obviously. I think the biggest barrier, though, is the lack of data to allow us to do proper bias assessments and equity assessments. And so I can't look to the public and say, we're going to deploy this model. It's going to order these automated tests for your kid when you come into SickKids. And this model is equitable regardless of your ethnicity, regardless of your race, regardless of your religion or your belief or your cultural practices. I can't do those assessments yet because I don't have the data to do that. And we know that that has to be done, right? I need to be able to, say to the public that yes, we're going to add this incredible efficiency. It's going to be awesome for you. Your wait's going to be shorter, and it's going to be equitable. And so that's a massive barrier, right? And that we need to solve. And the very last one that I'm really passionate about is around connectivity and internet connectivity. And so across the province, most people don't have access to proper, high-speed, reliable internet. We're going to be translating these AI models into people's homes. That's going to create a gap, right? And so in the next 5 years, as my research takes off, I may accidentally, inadvertently widen the healthcare gap for those who don't have connectivity to connect with these solutions. They're going to be left behind. That's terrible, right? That's the complete opposite of what we're trying to do. And so there needs to be a lot of advocacy around creating these internet foundations across the country to make sure everyone is plugged in and has good access. I could talk forever on this stuff, so I'm going to stop. I'm going to stop there.
No, that's just, all right. I think that like a good academic, I have a few slides, so Ashley, what? No, not 21. No, but, all right, so we'll see if the slides are not ready, that's fine. Yeah. Okay, so it's not, the title is unnecessary, but just, okay. So just, my name is Aviv, I'm a law professor at the Higher Ed Law School in Reichman University, and I was asked to talk about the challenges. So I think that the elephant in the room, which is not really an elephant today, but it's practically some version of an elephant, is what we call data. And data is the big issue, and this is also the challenge, but also bear significant potential. So the main issue, the main problem that we have today with data, and I guess some of the the speakers here will address this too, is that we have limited access to data, what we call high quality data. And people that are deals with AI will tell you that we don't only need just data. For developing AI, and especially AI in certain areas, we need what we call high quality data. And that's a significant barrier. And this is something that we need to learn how to resolve, because without that, I think that it would be very difficult to continue this exploration and development of AI technology in health areas, but also in other fields. And the reasons we have these barriers, and this is what I want to highlight for this very, very short presentation, I'm not going to exceed my time, is what we called copyright, and I will talk about this, the one barrier in copyright, and the other two barriers in other areas of IP. So the issue with copyright, I think, is something that we all know, and we talked about that earlier. And there is the fact that you own your creations, you own your data. Data is basically a resource, and you have ownership on that data. But the situation with AI, and this is a question that I think it's something that I reflected with Professor D'Agostino back in, I think it was in 2018 or 2019 when Professor D'Agostino presented a paper to the Parliament reviewing the Copyright Act, stating that we have to face that in a different way. Because we should look and see if we can address data for the purpose of AI within building a different mechanism in order to make this data accessible for developing what we call important AI startups and companies that will help humanity. And I think that in a way, this way of perceiving a copyright and perceiving data for copyright purposes is a very different mechanism than what we know today. And this is exactly what we try to pitch, saying that we should think about lowering the copyright standards or allowing this access for certain creations, certain data for these purposes. So that's one issue that we have to face with. The second problem, the second issue is what we call contracts. And this is something that you probably don't think about that, but this is another issue that we raised, what we call data mining. So you all know that, and you might think that we have unlimited access to that on the internet. But the fact is that it's not true. Because if you look into the internet, everything is basically, you have some sort of walls, it's called contracts, terms of use. You can't really use certain data on the internet, so it's not really accessible for you. And the second barrier, and this is the way that I try to frame that, and I know that bears criticism, and some of my colleagues in Europe will, criticize this version of this perception of privacy as barrier, but we should call this as it is. Privacy is really important, and I know this is something that we've seen in the last few years, mainly in Europe with GDPR, and I think in Canada we saw that more recently. And privacy is really important, but privacy, as any other right, has certain price, and we have to face the price and understand that. And when we look into what is happening with the healthcare, and we look into health data in that regard, I think that some of the people here will admit that when you need to address privacy concerns, this have some certain cost. And again, I'm not saying that the cost is not important. I don't think that we shouldn't pay this cost, but I think that you at least realize that there is a cost, and we have to, in the discussion, in the legal debate, in the policy debate, this cost should be something that we should consider, see if we are willing to pay this cost or we are not willing to pay the cost. But the issue that I see as an academic, as a scholar in the field, that I don't think there is many people that are actually discussing the costs. And the cost is something that, might create some barriers for developing this type of technologies. So I think that the issue that I want to raise here, and obviously I'll yield the floor to my colleague, and maybe we can talk about these issues more, is how we create a new regulatory framework for that area that will take into considerations all the problems, that will take into considerations what we want for the future and the importance of developing AI tools in healthcare, and also try to build some limitations and consider the problems that we are facing with privacy and copyright and other elements of law, and make those laws and make those legal frameworks something that will work eventually for us, for the public. So, yeah.
Thank you. All right, now we can turn to Mary Jane Deckman.
Hi, everyone. I'm Mary Jane Deckman. I'm a managing partner at Inc. Law, and we have a global consulting company, aptly named Inc. Consulting. Very happy to be here at Osgoode. I'm a 96 grad, and it has transformed in the time since I was walking the halls. I was thinking a lot about health and data even back then. I had the good fortune to article at the Ministry of Health Legal Services branch back in the mid-90s. My first file was the Personal Health Information Protection Act, which took, I think, between about 1995 to 2004 to come into force in Ontario, and so we've seen a lot of movement over time. So I take the point quite closely about privacy, because I think it's so fundamentally important, and yet it cannot be the barrier. I think there has to be a very good conversation about data and the opportunity of data, the opportunity to innovate and transform the health system and give opportunities, and not to keep some of those opportunities away from the people who entrust us with the data. So I wear a few hats. Right now, I've also stepped in as interim VP Legal and Risk at the Center for Addiction and Mental Health. I'll be there until we find a permanent person, so if anyone's looking. But when they asked me in May to come back in, I did say to them, I want to talk about what you're doing with data. The Krembil Center for Neuroinformatics is situated at CAMH, and there is such opportunity. And I'll say a couple of things because we're being asked about what are the opportunities, what are the barriers. It's all back to the data. And I probably am simplistic because I think quite often in the health system, if we had the right data, to your point about quality data, we don't always have that. So I've been thinking a lot about the continuum. It doesn't matter what shape it is. Is it a circle? Is it a rhombus? Is it an infinity loop? I keep thinking in the health system, let's get to, do we know what data we hold? Because we often talk about the electronic health records. Many hospitals have many systems. So in addition to a main system, you may have 300 other systems. We used to worry about legacy systems and all of those talking. I'm actually saying peel it back, figure out what is the data we have, what is the quality data. And I've been at some conferences lately, including in Boston, and I'd been thinking and drawing my circle or continuous loop on the data path. Should we be looking to clean all the data? Well, it's almost impossible. So which piece in the loop do you do first? You find your data, make sure you've got clean data. Maybe it's being driven by that use case. How do you vet your use cases at the other end? I think along that continuum, this path, once we have quality data, there are a couple of things that are extremely important. So I'll count privacy as one of them. And I would never minimize that, but it's a must do, but it cannot be a barrier. And every now and then when I'm at different tables, someone will sort of say, well, legal and privacy are impeding us. And I've heard it over the years in health research as well. We don't want to impede science. And I keep thinking, no, I think legal and privacy should be there to create the appropriate guardrails because, of course, we don't have the regulatory framework as yet. We're waiting on Bill C-27 in Canada. We see, draft bills in the U.S. at local levels, some state legislation. We've got a federal act to look at. We know what's going on in the EU. So we're monitoring carefully, but the fact is it's happening now. And at least 3 years ago, my law partner, Carol Piovesan, and I were in Orlando and Barcelona talking to global CIOs. And after doing a session on artificial intelligence, one of them came up and he just looked at us and he said, I'm scared to do anything and I'm scared to do nothing. And for me, that really encapsulated where we are. Fast forward, you see what's happening at Sick Kids and CAMH, and I'll shout out to my friend and colleague, Dr. Mohammed Mamdani at Unity Health, St. Mike's and its other sites, hospital sites. They created a VP position on data science and advanced analytics, and it's not every group that has done that. So again, Sick Kids is doing some amazing work, and the teaching hospitals are stepping in. We're working with community mental health and addiction agencies, community health centers, family health teams, to say, get to the data. What are the problems that you want to solve? And one of the things that we've done at St. Mike's is they developed a great path to figure out, well, what are the use cases? Because the things that we can change in the health system are almost endless. But what they did was they created a priority of what would have the best impact on patient outcomes, what would change things in terms of the health system. And if you come forward with a use case that perhaps can do both, then maybe it carries some weight and gets the priority. But we are really in this transformative state. When I sat at the Ministry of Health all those years ago in a little airless room going clause by clause as a summer student thinking, I'm not sure I'd want to do this for a living. And yet here I sit. We are at the cusp of some amazing things. We need those guardrails. And what we need even in the interim is decisions about what standards to adopt. There's some great frameworks out there. We may wait a little while for the pure regulation, but what are the ways we do this in an innovative and responsible way? So I'll leave it at that.
Thank you very much.
Hi, I bring a different perspective. I'm currently counsel at Norton Rose Fulbright. Prior to that, for about 20 years, I worked for a technology company. About the last 8 years, I worked for a company that operated in the mental health space. So using AI to help people meditate and improve their mental health is what we did. And you know, as I worked with the different engineers and you know, different people in the company, I tried to emphasize the importance of thinking about how the algorithm was built, how, you know, what kind of data was collected. Is our data too specific in terms of the type of people who use our wearable device? You know, so there are so many issues that we need to worry about from an AI perspective in terms of the quality of data, you know, if your algorithm itself is biased, if how you're analyzing the data, all those things are important to consider. But what I've seen over the last few years, and I think all of you have probably experienced, is that using wearables has become more mainstream, and as it's become more mainstream, it's helped us all to gain more control over our own healthcare. And you know, we can use the input that we receive from the wearables that we wear to improve our own well-being, and also get assistance from others to improve our well-being. And with AI, as there's more data, and hopefully good quality data, the algorithm gets better, and the data that's there is going to help us take control over our well-being. So yes, I agree with all the panelists here. Privacy and individual privacy is key. Regulation is really, really important. And you know, making sure that we are aware of bias. There were 2 students sitting at the table with me earlier today that come in from Nova Scotia, and they were engineering students who decided to come and talk, you know, to come and sit in on this concert, this session today. And they were saying that in engineering school, they're never told that they need to think about bias or anything else, as you know, and I think a lot of panelists earlier today talked about the fact that we need to have a multidisciplinary approach. And you know, whether it's healthcare or any other form of AI, I'm a big subscriber to using multidisciplinary teams to improve what what we can achieve, but making sure that appropriate regulation is in place and appropriate training.
Very well said. So, hi everyone, my name is Laura Pio. I am actually from the technology companies who are always speaking that you should leverage AI. I'm specifically a data and AI specialist that supports our entire public sector for Ontario, and I also cover healthcare nationally. So I'll work with Ontario Health, the number of hospitals, and you're talking about other sensitive, like what we'll call industries. I also work with like policing and law enforcement. So I completely echo and agree with everything you're saying. And to the engineers, I also empathize with you because I did not plan for any of this either before coming into the role. And it was a very humble learning once you step into it. So in regards to the positives that can come from it, because I know a lot of the times we spoke for barriers, and like we as Microsoft are still navigating and going through this, the more and more organizations that we work with and the increased number of use cases that are presented to us. So there's a lot of benefits that can come from it. And like we'll say the actual bettering patient outcomes is some of them. Like the fact that we can have a better response time on how we should triage ambulances, depending on the ailment of the person, and direct them to the appropriate hospital based on capacity and types of doctors available to provide the service. If we can identify what EMRs are doing, or sorry, what we're gonna say, like the actual respondents in the ambulance, what they're doing, like points of care while you're in the ambulance to do a handoff, were any of those practices better? Is there something that we should implement? Like all the way to using drones to take organs from Billy Bishop Airport and to avoid crazy Toronto traffic and airdrop them off at a hospital in record time. I mean, there's so many benefits that can come to improving cost of care. Like we saw during COVID, like, and I agree with you on connectivity, that's still always going to be a barrier to it, but just increasing accessibility to healthcare now. Like, I'm not sure if anyone really knows this, but at a lot of Toronto libraries, the most checked out item is actually the Rogers Wi-Fi or internet hubs, just because people want to use them to get access to internet. So it's how do we start to make that better distributed, because technology is there, and now to be putting it at points of like our people's fingertips. So like, there's a lot of good that can come from it, but there's also, like we said, a lot of learning that should be presented. Like when we talked about data quality, so I see this when we talk from hospital to hospital to hospital, like, yes, there's a lack of understanding of the data. Half the time, not everyone knows where it is in those multitude of systems that you've discussed. Like even just something as simple as terminology. Like when we use the word gender, is that gender at birth? Is that gender that you now identify as? Is it just binary, that we're only using terms as male and female? So there's even a lack of what we call standardization or guidance. I'm like, and it's, again, it'll vary by institution, but it hasn't been as prescriptively given from the governments as of yet. So it's, what language are we going to start to use so that when we are rationalizing over this data, it's in sync? That what one hospital is using the same to the others, what one province is using is the exact same to the others. So I'm like, we're finding that to be a bit difficult. We're sitting there and it's even just governance over this data, right? Like we talk about ethics, like that's a very, like what is ethical use of data, right? Like I sit there and I got Facebook on my phone, they take everything. Like we all know that on the consent agreements, but it's very different when you're taking all my personal health like information. Do I feel comfortable doing that? When do you need consent from the patient? Like if I'm about to die and an AI algorithm can tell you instantaneously you should do A, B, C, D, do you need my consent at that point, seeing that you saved my life? Was it that worth the trade-off? So the more that we go through this and we speak with the organizations, like all these questions are coming to light. Like who can use the data? How should they be using the data? Is de-identifying my health records enough? Is that fair enough that you've stripped just my name, but you're using the rest? Should researchers be able to use it if they are technically getting money from a government, which could be looked as capital? So it's like there's a fair number of questions that come from it. And I think the more and more, like I'm fortunate enough actually to work with Sick Kids. They're one of the best customers that I have. So I'm like, I'm not just saying that because you're here, but I love them so much. But I'm like, fortunately for them, like they're choosing to be like trailblazers down this path and helping us to define it. And it's something that they're then speaking to another hospital about and to another health authority and defining it. So it's, we'll need to learn, unfortunately, as we are going. I'm like Australia and the US and in the UK, the UK has the national health system. So I'm not sure if everyone knows that's an actual federal or national sense. So what they can apply will apply to all. We're very fragmented in Canada, not only in our provinces, but even in points of care. Like mental health is different than a hospital, is different than what we're doing for long-term patient care. So there's just a lot of fragmentation. And until we have this standardization, we'll see a bit of struggle for it. But like I said, I think the more and more people are willing to come together, participate, define those terms and work, we'll see the betterments for it.
Thank you very much. So that was a brief introduction from a number of different perspectives. I do invite questions from the audience, both online and from the floor. But let me start off. So clearly it comes down to data. So we've heard a lot about that. We've heard about potential bias in the data. We heard about connectivity, maybe a digital divide. Might be segmenting out different groups. What do you think Canada needs to do in order to facilitate better and safer access to broad and representative data? So kind of a big question. We touched on a few elements, but if you can kind of think of it from a Canadian perspective, what can we do to be leaders in here? And I'll open it to anyone who wishes to jump in first.
I'm happy to just, so I think it's a very important question. And I think the solution to some of the issues mentioned here is basically comes to the government involvement in this, in creating the infrastructure. And one of the ideas that I came into, and I think it's an idea that's worth exploring, is creating data. And I know it's very, and you probably have something to say about that too, but I know it's a very challenging way, and I think it's a very challenging thing to do, creating data. So first of all, how you create data, who should be responsible for creating this data. But just from learning from some examples in Israel, this is one of the initiatives that the Ministry of Science is doing for the last, I think, 3 or 4 years. I'm not saying that is actually really good right now, but I'm saying that it's something that might resolve some of the problems. And I know that creating data, what we call synthetic data, is not always a solution. And some of the engineers that I spoke with, and maybe you have to say something, you might have say something about that too, told me that it's not really perfect and it's not really reflecting or resembling actual data. But I think that if we try to think about what we should do ahead, and considering the issues that I call that, privacy as a barrier, but obviously as some of the other panelists mentioned as well, we should also be really aware of the issues, of the problem that we have with privacy. So I think this is exactly what the government should do, and explore this area and try to find ways to creating data for researchers, data for companies, for startup companies, not only for public use, but also for commercial purposes. Because I think this is one way that we can support this type of initiative, because these initiatives cost a lot of money, and I'm not saying that the government should be responsible for putting all this, all the funding for these projects, by the government. It might be some sort of an industry and some sort of cooperation between government and other partners as well. Yeah.
I'd like to offer a differing opinion to that. If you're relying on government to collect that data, the type of people that interact with government and government-related organizations are not reflective of the entire society. So that data in itself could end up being biased. And so, I think that being aware of who's touching that, whose data you're collecting is really important, just as important as what biases are going to be included in your algorithms. And so I think that it may be one way to look at it, but also to consider that.
But just to comment for that, I'm not only saying that we're creating the data, but by collecting the data, but also creating the data. So you're right, that's one of the issues that we are facing in research right now with government, is that it's not really aware of all other partners and all other groups. But that's why I think that the government should be responsible for facilitating the project, but obviously it's not supposed to be a project that the government will, only would be the only partner, because if that would eventually happen, I agree, that will result in certain bias issues. But the government should be willing and able to lead the project and to lead a group, building a consortium of partners that will create this type of synthetic data.
Yeah, I would also add that it's not that I don't think government can do it. It's, will it be done in a timely way? We look at the legislation, for example, and the fact that we don't have the regulatory framework. And I think of other components along that data continuum. I'm back in my loop. Things like cyber standards, de-identification, as you've said, and that is a moving target as to whether it's truly identified once we start thinking about the data linkages. The governance and oversight, at some point, are we going on trust or binding people contractually? People can break contracts, but often users will say, just tell me what I need to do. The health researchers will say, tell me what I need to do. Please make it simple. I will do it, but I want to move forward. So one of my concerns is if we are waiting on a national, robust solution, I think it's possible, but in the meantime, we still need to continue to advance. So I look at every project as to what data are we talking about? Is it identifiable? How did we get it? Lots of questions about, as you've said, the bias, and I know bias assessment is the next frontier for sure. The de-identification, when we gave a definition to the term de-identified in PHIPAA, the Ontario Health Privacy legislation, years back, it was not reasonably foreseeable in the circumstances that it could be linked to identify you. And now we're talking about coded data. Coded data generally is data that you can remove identifiers, and someone here probably has a better definition, but just in terms of the ability to re-identify it. And the drafters came back some years ago, not that long ago, and said, well, we'll call it de-identified data, and we'll put a prohibition that we used to put into contracts saying third party can't attempt to re-identify it unless the health information custodian, say the hospital, healthcare provider, says they can. And I'm thinking, well, doesn't that mean that it wasn't de-identified in the first place? So again, I think there probably is an imperative to explore some of the technologies, including synthetic data, but it feels as though we need to do all of these and carry on in the way we did with cyber and de-identification, where industry and the health sector has simply said, we're going to keep moving. That's what Sick Kids is doing. It's what St. Mike's is doing, CAMH, other organizations. Because if we wait, anyway, I know it is aspirational, but it is here now. And so what is the way forward in the moment?
I can weigh in a bit. I have some conflicting thoughts. And when we talked as a group, we said, you know, the panel might get spicy. And so I think some of the comments might heat up a little bit. From the synthetic data perspective, from a machine learning programmer perspective, often you think about leveraging synthetic data when there's an absence of data available. And so maybe rare diseases, you know, there's a project I have that looks at 3D photography of kids' heads, and some of the syndromes are rare, and so we use synthetic mechanisms for creating expanded data sets. But I think if you have the data available, then saying synthetic data, let's just use that, is like a crutch. It's saying that we can't figure out policy, we can't figure out access, so let's just make fake data and then build models off of that. So I see that as a bit of a crutch to not actually figuring out the issue at hand, which are solving some of these barriers around access, around regulatory, around privacy, et cetera. So that might not resonate well with people, but I think that's the truth. The other piece is around, I'm conflicted from this whole idea around government versus startup and industry and who's going to solve this. Because when I think about things from a patient perspective, we really need sound policies, procedures, guidelines. Like, we need to make sure that we don't have accidental harm translating to patients, that physicians aren't accidentally using these tools in inappropriate ways and leading to patient harm. And so to me, that's more of like a government role. It's a regulatory role. It's the regulatory colleges that govern me as a physician have a role in that. And so I think there's a really important place there. But then when I put my startup hat on, the very models that we want to translate, you know, very early next year, I can't get regulated, right? And the irony of it is I think these modeling techniques are actually safer than the models that are currently able to be regulated. Because they can adapt and adjust to changes in environment and equate for like shifts in demographics and bias and whatnot. And so in a sense, the innovation in the startup space is actually a safer type of approach than what can even be allowed from government. And so that creates this interesting dilemma when I'm listening to these different opinions. There needs to be a role where both parties sort of synergize. And if, you know, in this instance where we can't regulate adaptive machine learning models and we're totally holding back the field of AI in Canada on that front, there needs to be a mechanism where one can still apply to Health Canada and demonstrate safety, efficacy, and get it approved while we wait for a national regulatory framework to be put into place. An opportunity for organizations like Health Canada to learn from that cutting edge innovation. So how do we enable both, right? I think is important. And I love the synthetic data because I use it, but I just like, you know,
Yeah, it's not perfect.
I don't want it to be a crutch for people to say, oh, let's not figure it, just make it.
Yeah, it's
Right?
actually really funny because this is the type of conversation you always have between lawyers and practitioners and industry leaders. So we are lawyers, so we are thinking about, you know, certain structures when in fact when you look into, you know, someone from the industry will tell you, I don't need these, you know, structures. You need to solve this issue for me. Don't build some, you know, some
pathways.
Yeah, you don't build some, you know, very, you know, nice and elegant legal framework. Just do something that will work for me.
Yeah, we need pathways to enable the translation of this technology safely, right? Easier said than done, but that's what's actually needed.
I'll add one quick thing before we move on. We also have to get the public in it. And so we spend a lot of time on, do you need consent? Is it notice? What is the story we are telling? And when I say story, and I say this quite often, when I say story, I mean a true story. But historically, over the years, fundraising or other initiatives in healthcare, there were certain patient populations where we said, well, no, we better have a list of, we can't reach out to them, or we won't have certain people, patient groups participate in health research, for example. And ultimately, this data conversation, this is my data, this is your data, it's everybody's data. And the story that people hear is what they see in the media, the negative, everything that's gone off the rails, which is happening in real time. And yet, what is the positive story about data and the moral imperative to harness the data and move this forward with that engaged partner? So I think it may be a competitive advantage for the companies and organizations that do it. I'm not saying that's exactly the right reason, but we're not doing a great job, at least in my view.
All right. Well, thank you very much for that. I see we may have a couple of questions from the floor. So let's turn here, and if you could please introduce yourself.
Okay, this question is for Dr. Singh. Dr. Singh, I'm also a doctor, and we work in evidence-based. So my question really is, taking into consideration safe and efficiency of using AI, do you think, in your experience, the cost of healthcare will go down because of using AI? Because if that's the case, then I'm sure the government will say, that would be a good, they will listen because of that. And the second question really is, I don't know if there is somebody from the from the insurance company here, because if by using AI, will my malpractice premium will go down or will go up?
Can I ask you one clarifying question? I know you didn't ask it to me, but by cost, do you mean financial cost, or do you mean like the cost of what could be on care, the cost on successful outcomes?
Overall healthcare, if using AI, because it's more efficient and it's targeted, it will come down.
But do you mean like financial cost, or do you mean like successful outcome cost? Like, do you mean cost on human life?
Of course, you're taking into consideration the safety and efficiency. Basically, that's it.
So thank you so much for that question. I mean, the holy grail is sort of improving time efficiency, reducing cost, and improving care, that triangle, right? And so it's almost impossible to do. You usually think that if you're going to improve time or care, you got to increase cost. And so there's this like dream state where maybe machine learning, because software can be automated, software is cheap at the end of the day once it's developed and deployed compared to human labor, that maybe that is the holy grail and AI will be able to enable that. Certainly there's going to be a lot of additional costs though, right? So once you build the model and deploy it, you need teams of people to ensure that the model is continuing to work really well, right? And you need teams of developers. And so we might see a shift in where cost is being occurred, or where cost is being spent, or money is being spent. But the promise of AI is just that, is that we reduce costs by gaining efficiency and while simultaneously improving care. And that's sort of what we're working towards. And I think when you talk about evidence-based medicine, we're getting towards this frontier now, particularly at SickKids, where we've built these models. We've validated safety in a prospective silent trial, which means you just deployed it, you see that they're working, but you don't have it influence care at all. And then we need to move towards deployed clinical trials. And it's in those clinical type trials that will then generate that evidence to see, are we improving care, improving efficiency, while also doing cost analyses to see what happens. It's tricky in a publicly funded system, and at SickKids we're salary based, and so like we kind of make up these cost units, and so how relevant is it actually? It's a little bit tricky to measure the cost efficiency, but we're at the stage of doing that right now. And then the second part of your question, which I'm temporarily blanking on. What was the second part of the question? I'm coming off of a night shift, mind you, and I haven't slept yet for a long time. And so maybe if you can remind me, just shout it out from
Is it with the insurance?
the insurance. Oh yeah, this is a big dilemma. Yeah. Well,
You're using AI because if they believe it's more efficient, then
yeah.
we'll cut it down.
Yeah, it's interesting because then what you're kind of getting at is what is the standard of care going to become, right? And will leveraging machine learning become a bit of like an early adopter thing where it is perceived to be a bit more risky, so insurance goes up? I don't think that's actually going to happen, though, right? I think what's going to happen is the shift to the standard of care will become, this is a machine learning tool that's validated and it's determined to be more safe. And so it's expected of you to use that tool and to practice in that way. How we figure out assignment of liability, like if the hospital purchases the tool and you as the physician use it in a scenario, but it's purchased from a third party and something goes wrong, who's liable? I think that those questions need to be answered, and the solution will probably be determining on like where the failure point was. Did the software fail? Did the physician use the tool in the wrong way? Did the, well, I don't know, the hospital has a really clever way, they have some very smart lawyers of downloading their liabilities to everyone else. And so, but will the hospital be liable? And so I don't think insurance cost is really going to change significantly. But I think that it will become expected to be insured that you follow the standard practice of care, and that will eventually become leveraging these machine learning solutions.
Yeah, I have had questions from clinicians saying, what if I don't agree? So again, maybe the tool ultimately says, you know, we've got a 96% predictive outcome that is better than our, you know, best or our average or whatever it is. But I've had clinicians at different junctures just say, but what if I don't agree with whatever I'm seeing and I'm going to go with my clinical judgment? So I think, yeah, there's a lot to be determined on it for sure.
All right, thank you for the question. We have one more from the floor.
Oh, two more.
Oh, two more. Okay, good.
Hi. Dr. Goen touched on the significant cost of developing quality data sets, and I think Ms. Bawa has illustrated very well the tension that causes with stakeholders when you try and utilize that more broadly, not just the person who develops that data set, but now they've got an asset that they're trying to, you know, whether it's commercialize or utilize. Unfortunately, in the data space, we don't have something like the legacy system of the patent system that allows that collaboration while reassuring those stakeholders. We've heard a bunch of great solutions from the panelists, but I'm wondering, in the absence of that legacy, have you, as people who are in the trenches and in the field, seen any of those solutions that have gotten more traction than others? We can evaluate those solutions by their, you know, by what we suspect they're going to produce, but also we can evaluate them by have people adopted them, employed them. I remember 3-4 years ago, we were talking about the E-Diamond case and data governance as a way to prevent that tragedy of medical information from occurring. 3 years, 4 years later, have we seen any of the systems that were proposed back then, or even these new systems that you propose today, gaining any traction and any movement in the space? Or are they still generally theoretical?
Who would like to take that one on?
I feel like I can't answer this without being slightly biased. Like, can I use the politically correct IT one and say it depends? Like, is it?
That's a legal one,
I know it's
too.
also the legal. I notice everyone
On
uses
the one
it.
hand,
But
on the other hand,
yeah, I can sit there. So I'm like, okay, like, so we from Microsoft will come and speak and attest to this. That like, we have a number. Like, when you come and you talk to us, we always have a bunch of what we'll call Lego pieces, and we build them, and we work with yourselves to identify what do we need to capture. What use cases are we going to be aligning to? What's terminology that we have to be respected for? Like, even in healthcare, we've created a specific subset of tools just to be able to see the terminology used in health and understand it. So, like, I can come to tell you our suite can come to do it all, but we also work with hundreds of thousands of partners, each specialized in varying industries, all coming to and saying the same thing. So I don't think that there is a silver bullet that's for it. I think there is certainly a much better understanding and focus now, because like we know PHI is sensitive data, like a lot of institutions work with the banks and beyond that have PII data, which is also sensitive. So there's more and more respect being paid to it. But again, I can't tell you that anyone has, Microsoft's gonna be pissed, but I'm like, I can't tell you anyone has a magic button for it. It's just, we'll be working with yourselves and everyone in conjunction. Like a lot of the times we just make sure, especially on governance, like we think of things people, process, technology. So I'm like, have you gone and identified, like, do you have the stewards and such that are put in place? Like, have you done, what terms are important? Like, have we looked into metadata? What are we gonna need to tag? What are we gonna need to analyze? What are we gonna need to catalog? Again, what's that terminology that's set? How are we gonna explain how the data is being used? Like, who's touched it? How have they changed or manipulated it? What data should be presented to them? So I'm like, there's a lot of facets to it. Again, like the tech's just one piece, and I'm like, really, like, it can be whatever you want it to be. Like I said, there's Microsoft, we got another hundreds of thousands, Amazon does it, Google does it, like all of us will do it. But I'm saying it's the people and processes part which we have to dive into even more so and best define and then go and execute on that. So I'm sorry, I wish I could say yes and that there was a one magic bullet, especially as Microsoft, but I'm like, I unfortunately, I can't.
But then also, like, what are the values you want to bake into that
That's-
process, right? Like, and how do you define those values?
It is some of the hardest. Like when we work with customers on this, like this isn't a like buy the button, press it and it works. Like this is multi-months to years, because then you're constantly refreshing, you're constantly reevaluating. Like how a model drifts, so does all of these values. So I'm like, it's something you're gonna have to continuously invest in and evolve and challenge and re-identify. Like you're right, like it's never, there's no one-stop shop.
Right, and so I guess my question is have you seen certain of those elements gain traction? The reason I bring this up is like Ms. Babas mentioned, there's an element of public adoption. I'm sorry, I think Ms. Dykeman also mentioned this, that there was an element of public adoption and bringing it to the public. That is something that when we go and speak, you can talk to, right? The patent system, I brought that up, is something you can talk to because it's a more broad system, right? And so it's a little bit more understandable, although albeit complicated. So I was just wondering if there's something that gets put forth more often than others. That's really good. No? Thank you. And that's an honest answer, and I appreciate it. So, thank you.
Right, thank you for that. We do have one more question from the floor.
This is from Andrea in the chat. She asks, as one speaker noted, AI-driven innovation in health is a multidisciplinary team sport, and these team members don't always come from the same organization. Beyond benefiting patient outcomes, IP often creeps in as an important issue. How can we think about IP models that incentivize all players appropriately?
I could give a little bit of a plug on what we're experimenting with on the industry side with SickKids that's working really well. And that's just that we have access to all of this rich streaming EHR data for the purpose of creating these real-time models, deriving real-time insights. But regardless of who builds the model, whether it's someone on my industry side, whether it's someone on the SickKids side, because it was built off of patient data, physician data, we have this deep respect for how that data was generated, that the IP will always sit with the hospital. And we made that decision because it then just removed a lot of the barriers to collaboration, right? I thought it was the authentic thing to do. Like, people suffered in hospital to create this data, right? And so the IP, in our opinion, should be owned by the people, and in Canada, those are the hospitals. It was also a way of sheltering the IP from investment. As we go and fundraise in the next couple of years, we're going to get investors from who knows where. I want them to be Canadian, but even when you think they're Canadian, the money somehow comes from the US. And then what happens inadvertently is Canadian IP gets exported to the US even when you never wanted it to be. And so having the IP owned by the hospital and having the AI delivery mechanism be the thing that's owned by the startup is a way of sheltering the IP even when we get investors from all these places. And so that strategy has been really popular for us. It's broken down so many barriers in the hospital for collaboration, and it's one approach.
I also agree with that again, and I'll just speak from the platform advisor. I feel like if you leave a lot of this with any one of the vendors that's providing the platform for it, you're going to have a view that is specifically sent to what can be monetized and what can be reused at scale. So a lot of times when we sit there, it's, yes, we want to make sure it's our customers that are owning the IP, that they are owning the collateral. It is their data. It is not something that we have come to create, because then you'll have questions of the transparency behind it. You can have questions on, like, again, what bias was coming from behind the algorithms and beyond it. What's the use and how's it being extended at a multitude? So, like, I agree with you. I think it should truthfully come from the institutions, and like we're saying, and then it is everyone who would like to participate. You should be providing, like we're saying, what is the level of support, but always in guidance of that it is, like, if it's the institution of any kind, for the best intention. I don't ever agree that it should be like the platforms that are doing it. Like, I think about some of the EHRs, and it's almost like a little black box where it's like you just get an output and you have no idea how the data is being used or what data is being used, and if that's being resold to another 37 plus institutions on the back end. So I'm like, I wholeheartedly agree with you on that.
Right, thank you. We have another question here. Ian?
So it sounds like good work is being done at the research hospitals, and that Sick Kids, for example, and Unity, are doing a really good job keeping the bar high. But we've also heard that, Devin, you're saying you're not regulated by Health Canada when you're building a model in-house that isn't for commercial, or you're distributing it in some way. So my question for the panel is, how do we make sure that the wonderful work being done at the very rich hospitals in the middle of Toronto on unique patient populations, for the most part, and benefiting unique patient populations, finds its way out into the community hospitals, so that we're not, by building AI, again, further creating or exacerbating inequity within our healthcare system? What kind of solutions are being bandied about in the industry?
I just want to jump in real quick and put my lawyer hat on, even though I'm not a lawyer. And I did not say that we're not being regulated with what we're building in-house, because there's lots of regulation that we're paying attention to. But I mean, to your point, Ian, like, if we build a model at Sick Kids and we want to translate it to another hospital, rapid fire, what are the barriers? Well, how do we get access to their data? So do we deploy on-prem, or do they feel comfortable putting it into a cloud? And there's all those privacy concerns that hospital have. The second piece is then, if I'm going to deploy it from Sick Kids to another hospital in a sustainable way, I probably need to sell it, or I need, like, government to pitch in and say, hey, we're going to fund this program because this is awesome, and therefore I don't need to sell it. If I'm going to sell it, it needs to be regulated. And then the types of models that we're all building these days can't be regulated because they're all adaptive, because that just makes sense. That's what we should do. It makes no sense to build a static machine learning model that then deteriorates over time, but that's what we regulate at Health Canada. And I love Health Canada because we collaborate with them. But that's just like the state of affairs, right? So we can't do it outside of, like, research agreements. And so we may have a trial of some kind, or we may create an REB approved research study that allows us to, pool our data together and deploy these models and get something off the ground. But that's really just like a cloak to, a proof of concept that actually isn't sustainable for the long run. And we do that while we wait for, the folks in this room to help us figure out how do we actually move this work forward.
Yeah, I'll pitch in to agree on that front, because again, amongst the teaching hospitals and other healthcare organizations, often things do get couched as research. And I always think from day one back to, is it identifiable data? Is it going to be de-identified? Is there some other solution? But then once we're down the path, is it for healthcare? Is it for research? Is it for quality improvement or health system planning? We've got to figure this out, because quite often health research, as you know, in Canada is regulated. We have frameworks, we have guidance, we have things that need to be done. We don't necessarily have them in the same way elsewhere, but I've had a number of platforms that I've worked with where we started as research, then we morphed over to QI, and then we morphed back to research. And so we've been saying, well, let's not do it 9 times. Let's sit down and have an open conversation about all of the places this might go, and so that we can actually scale it, protect it, but we're spinning a little bit, I'd say.
Yes, we have a question from Professor Weber.
I was a little surprised, well, not really surprised, when you say IP should be owned by the hospital. That's neat from the hospital's perspective, but somehow what happened to the patient here? Can I suggest another model where the patient retains the right and exclusively licenses you, but so that you have rights that you can play around with, but that there are conditions built in to the relationship between you and the patient that enables the patient to have some control over what's happening to what is, I mean, we either calling this data proprietary to the patient, or we're calling it proprietary to the hospital, or we're calling it proprietary to everyone, right? It's difficult to say everyone. Ownership, joint ownership by 30 million people and their descendants is a tricky concept. So you have to, I think perhaps in those sort of rather more binary terms, giving you rights to transfer something, but not giving you total rights of control vis-a-vis the patient. And that's, I think there's a question there somewhere where you probably can divine it out.
I mean, I think that's a really great point. I mean, part of the philosophy of when we say, let's keep the IP in the hospital, really what we're trying to get at is let's keep the IP with the patients. And I know, technically speaking, it's not actually with the patients, though. It's with the hospital. And so what you raise is philosophically a really interesting idea that very much respects the patient's, I say suffered because I think going to the hospital is kind of suffering, to generate that data. But then when I think about operationally and technically speaking, how do we make that come to life? Is that part of a consent process? Does there then need to be like, almost like when you're a shareholder of a company and you want to make a decision, like to commercialize or release it, do then people get like a vote who contributed their data to that IP, and is there like technology that would actually enable that to happen? I mean, certainly it could be done if the right technical system was in place to facilitate. It also gets me wondering about a parallel concept that I worry about with the idea that we will withdraw patient data or the right to be forgotten, because that I think philosophically is the right thing to do, but I get worried from an operational perspective when I've trained a model and we've deployed it out, and then now I need to have the model forget that patient. Like, how do I operationalize that? And so there's like a conflict there that's really interesting.
I think the point really is, and you've suggested it without actually saying it, this is really a negotiation between patient and hospital. You can have set terms as part of a negotiation, consent form, but it's something which I think requires patient input, whether it's through a patient's collective initially, so you have sort of a collective agreement, as it were, with the hospital in relation to that. So it doesn't have to be one by one, but I think it's the way that you put it. I think I can see the notion of the hospital as a sort of a trustee for the patients and administering the IP on their behalf. Yeah. But the legal structure that you've put into place is, I'm the owner, so what the hell, I'm not suggesting that's what you feel, but that's the nature of the structure that you've suggested, where ownership means total control, is not perhaps quite the structure that I would find terribly conducive for patient welfare.
Yeah, definitely.
Right. Thank you for the questions and the great discussion. We do have just a couple of moments left. Perhaps I could turn to the panelists for a quick closing remark. And I'll just pose this last question to help frame that. The technology is moving at lightning speed. The potential for benefit is vast. And we know that the data security, privacy, rules, regulations have not caught up yet. How hopeful are you that they will converge at one point where you can actually start doing good work?
You want to go first?
Yes, please.
I mean, I'm very hopeful, right? I have to be hopeful because we're in the space, we're doing these panels, we're raising awareness. And so I'm very hopeful within the next 5 to 8 years, we'll see like a real convergence of some of these regulatory mechanisms coming into place. There'll be conflict with industry and with those reforms caused, but I think what we'll really benefit from is a clear runway of this is what we need to do to translate. But I do think that we need to step back from the technology, step back from the policy and all of it, and remember like these are human patients at the core of all of this, right? And so we need to stay human-centric in the way we build these models. We need to stay very respectful of what our values are as a society. How do we capture what those values are? I suppose that's through voting and the people who take office, but I think that these need to be really key issues that people then can have representative of their values that then get these regulatory and these privacy things put into place. And the only way that we're going to see true convergence is actually stepping back from the technology, the policy, and thinking about what are our values and how do we then capture those values in the way we build this system that enables AI to translate broadly. Maybe I'll leave it at that.
Okay, thank you.
Yes, so I share optimism, my friends, my colleagues. I think that we are on the right path, and I think the role, as my colleague Professor Zeidman said, law should not be causing any problems, and I think that the issue that we should stick and we should find resolution to is how to create the right balance. And this is also something that is done here with the AI in Society, a new center. I think this is exactly what we need to do. We have to frame the questions and try to look into the right solution that will serve society. And when we find this right balance, I think that we can at least take away some of the problems, some of the barriers, and look forward into creating something that is serving society better, and patients, and obviously all the other partners that are sitting around this table.
Thank you. Mary Jane.
I'll say even if the technology can do it, whatever that is, it doesn't mean that it should. So we'll go back to the multidisciplinary piece of gathering the people and creating a culture such that it does not go too far if for example, there's bias detected, or, we cannot explain it, it's not transparent, or there are harms that are being detected. Because we do a lot of work with developers as well, and they sometimes say, well, I knew in the room on that day that this was not going to end well, and there wasn't a culture where someone could step forward at that time. So I think that's a piece of it. Having said that, I'm extremely optimistic. I think we can do it.
I'm optimistic as well. The only thing is, I think culture is not enough. I think appropriate regulation. I know.
Oh, I'm in for that too.
Yeah, and being in industry when the GDPR came into force, it was the monetary fines that really resulted in traction, and the companies taking the right action to try and ensure that they were compliant. And so ensuring that the bad actors have consequences with appropriate regulation is probably something that we will need to really, enjoy the benefit of AI. So I think appropriate regulation that allows for innovation but also prevents harm is something that I'd like to see.
What I'll tell yourselves from the field, I'm optimistic more than, we have hospitals that are putting their hand up saying, we know this is important, it's something we want to undertake and go on the journey. We have the government not only saying the same thing, but also looking to create what are panels or what are what we're going to call SWAT teams to say it's something we want to focus. There's documentation called the Health Data Platform that our federal government's releasing. So I agree with you, Devin, on it taking 5 to 8 years. It's not going to be something that's quick. Remember, this is uncharted territories. Everyone's going to dip their toe really slowly into ice water, but just know that it's happening. It's been identified. Fortunately, we have what I'll call role models in other countries. Australia's done this. I said the UK, the US did what you just discussed now, where they said you're going to mandate your data on fire or else we're not paying any of your medical claims. And obviously that really worked quickly. So we'll have a number of things to look to that can help be a North Star for us, but more than optimistic. Everyone seems to know that this is important. I think now it's just figuring out how do we take saying it's important and actualize it. So.
All right, well, thank you all very much. Let's give the panel a round of applause for a wonderful presentation. Thank you.